And patients love it to the point that patients tell the family, the friends, the network, and new patients keep coming. GAE hemorrhoid artery embolization is one that is gaining much popularity. There is already enough evidence behind it, and the alternative treatments are very rudimentary and painful to the patient.
Somebody said something yesterday, and I wish I could quote them correctly, but they said direct-to-patient marketing works better for the procedures that the other people's doctors are not going to refer them to. Like your ortho is not going to refer you to a GAE, your colorectal surgeon's probably not going to refer for the HAE, and so you almost have to battle to go get that patient and help them not get the major procedure.
That's correct, and as soon as you started, you realize that, oh, why didn't I start like right there, going to the patient?
All right, guys, I'm here with my good friend and client, Dr. Amin Astani from NorthStar Vascular in Minnesota. Doctor, how did you get into the IR space?
Good question. I always wanted to do procedures, things with my hand, and I was getting a tour of all surgical subspecialties until I came across IR. With all the innovations, every year they come up with a new minimally invasive procedure that does better procedures, better outcome, less invasive, faster recovery. It was a no-brainer.
And so how long have you been doing it now?
Since 2015.
Oh, wow. Okay, so you've been in it for a while now.
Yeah.
You've seen the evolution.
Yeah. It changes so much that even in this short 10 years, you can see so much changes and so many new procedures that we do.
I heard someone earlier say that IRs have an identity crisis because they don't even know where they fall in. Where do you see the future of IR going?
So I think IR is going to be a specialty with many subspecialties, right? IR is becoming so wide and vast that some people treat cancers and specialize in that. So there's going to be a subspecialty, for example, IO, interventional oncology. Is the whole category of vascular disease, peripheral arterial disease, aortic work. It's going to be its own subspecialty. There is treatment for pediatric population. There's going to be its own specialties. A lot of us do neurointerventions in the brain with the stroke and aneurysms and tumors. It is already its own subspecialty. So it's going to be just like there was the general surgery at some point, and then there was urology, plastic surgery. It's going to be like that. It's going to be a general IR and 10, 15 subspecialties.
Now, with the current way, we're here at OAS with all the OBLs. Do you feel it's going to be that same flow where everyone's going to start at the hospital and work their way out, or do you think people will start coming even out of residency and going into practice directly?
I have seen a lot of interest in new graduates to directly come to OBL, but at this point I think the best way is to go through the hospital, gain the experience, be independent, know how to take care of complications.
Learn what you don't want.
Yeah, exactly. Learn what you don't want and hope it never happens in the OBL, but if it happens, you're ready to take care of it.
Now, talk to me. We've been talking a lot here at OAS about the new procedures, and I know you've been doing a lot of GAE. How long have you been doing GAE, and what do you see the future of the MSK side of things?
So GAE is one of those new procedures in IR, right? We have been doing it for 2 years. Its history is a little longer than that, but not that long. But already the outcome is so great, and we have followed the patients, and we have 2-year follow-up data that shows the outcome is lasting, and patients love it to the point that patients tell the family, the friends, the network, and new patients keep coming. So it's growing on its own, and it tells you about the success of the procedure. If it's not working, they're not going to tell their friend to come do the same thing.
How long do you think it's going to take for GAE to become like UFE, where UFE was experimental a while back, and now it's like the standard? How long do you think that'll take?
So there are some different components to it. One is the medical evidence and data, and that's not going to take too long because already there has been established some registries and some controlled trials that are ongoing, and results going to come out very soon, maybe in a matter of 2-3 years. But then the next stage is going through the process of insurance companies and convincing them that it's not experimental. Like for example, PAE, prostate artery embolization, we had evidence for a long time, and now starting just last year, some of the insurance companies agreed to change the designation away from experimental to natural treatment. It has been in guidelines, even urology guidelines since 2023. but still some of the insurance company label it as investigational. So that's a different component that is outside the actual evidence, science behind it, and it becomes the business of insurance companies and the politics, which unfortunately can take much longer.
So with that being said, what are some procedures that you see now, or you guys are playing with now, that you think in 5 to 6 years will be more standard?
So GAE is the easiest one. We have the most data, most number of research going on, and we already have good amount of data on outcome results and medium-term outcome. But along the same line, treatment of plantar fascia embolization is another one that is going along the same pathway. And in MSK embolization, musculoskeletal embolization, shoulder embolization.
You guys are doing shoulders, right?
We do shoulders already, and the outcomes are great. In elbow embolization for either tennis elbow or golfer's elbow.
Pickleball elbow is easier to say.
Pickleball now is more popular, right? You're right. And they are going the same path. It's gaining popularity. Away from MSK embolization, HAE, hemorrhoid artery embolization, is one that is gaining much popularity. There is already enough evidence behind it. And the alternative treatments are very rudimentary and painful to the patient. So there is a lot of interest there.
Now, let's talk a little bit about marketing, because you guys have done so much marketing. I mean, I know we've worked with you in a capacity for lead generation, but you guys are on social media, you're doing content, education. How did you guys get so focused and kind of really dive into it the way you guys have?
So initially we were hesitant. You know, most marketing, most medical practices, especially physicians, are not into marketing. You know, the general thinking is, you know what, I provide great care and it should speak for itself. But that's not the reality. Most patients don't know the name of the physicians, or they don't know the outcome. They can't differentiate between the outcome of the physicians, right? It's too complex for them to know, was this a good outcome or not? So just like any other industry, this is a business. You need marketing, you need presence, you need people to understand it. But so we had that vision from the very beginning. We started by small marketing budget, but very meticulously we followed the outcome and calculated return on investment. And it was very easy decision to increase that marketing budget, seeing those return on investments. Now our marketing budget is almost 50 times what it was when we started.
That was 5-0, just to make sure I heard it.
5-0,
okay.
And it's a very easy decision. It brings in more patients, and it pays for itself and remains a tiny fraction of the overall revenue.
Something I think it was Dr. Kowalewski said yesterday when I was talking to him is, so many doctors want to raise awareness for disease, but they don't want to market. He's like, they're the same thing.
Yeah.
I really like that. So now what channels are you guys doing marketing in?
So the big division right off the bat, is it marketing to end customers or marketing to businesses? And translating that to medical field is, do you market to other providers? Referring physicians is one category, and the other one is directly going to the patients, right? Most physicians think of marketing to the other providers, building up the network, which is absolutely necessary. It takes a lot of time to build that, but is lasting and is very effective. But the other arm, which is directly going to the patients, it could be as effective, if not more effective. And we should delve into it, and we have, and we're seeing the results, which is amazing, right? And for certain procedures, it's easy for patients to understand what we're talking about. Knee pain, for GAE, you ask knee pain ? Everybody understands what you're talking about. But if you talk about a more complex, like Y90 treatment for a specific liver cancer, patients don't understand that. You don't need to go directly to the patient. You go to the referring physician. For knee, you directly go to the patient. It's easy for them to understand. It clicks with them. Every step that they take is painful for them, so they're looking for solutions. The same for hemorrhoid. They are actively looking for solutions. Same for prostate.
Somebody said something yesterday, and I wish I could quote them correctly, but they said direct-to-patient marketing works better for the procedures that the other people's doctors are not going to refer them to. Like your ortho is not going to refer you to a GAE. You know, your colorectal surgeon's probably not going to refer for the HAE. And so you almost have to battle to go get that patient and help them not get the major procedure.
That's correct. And as soon as you started, you realize that, oh, why didn't I start like right there, going to the patient? The patient wants is actively seeking a treatment, and I have it. I just need to present it to them.
Now, curious, with some of the direct-to-patient marketing you guys have done, have you ever seen patients come in that maybe they had a knee pain, but they were actually a PAD patient, or this cross population of people that were undiagnosed with other conditions?
We have, and it was something that we weren't actively looking into, but it happened organically. Then we realized that, oh, patients coming to us, they're seeking minimally invasive procedures, and they have other things that we can treat. So now we're actively screening for that. We have the two-pronged approach. One is having some present in our waiting room, some brochures and some pamphlets, and also a TV with short videos, like 30-second, 45-second animation explaining other procedures. And we've seen a lot of interest from those. They come in for knee pain, but they also have prostate issue. Or wife comes in for a knee pain and the husband has prostate issue, and they come for that. And the other one is, during our intake form, we ask about review of system, and some of those review of system questions are directed to other things. We have venous insufficiencies, and we don't ask the specific disease, we ask the symptoms, but we're screening for venous insufficiency, peripheral arterial disease, genicular artery embolization, knee pain, for BPH, for fibroids. And we were surprised to see how many people have those other conditions and in treatment for that we can offer them.
That's awesome, because I think so many people get caught up in the, I'm going to treat a knee, but that knee patient is not, they're the whole body, their whole system, and there's so much you guys can do to help them.
That's absolutely true. And one other idea that we are exploring now is, instead of going for knee pain specifically, we can go for leg pain, because they may have knee pain we can treat, they may have plantar fascia pain we can treat, they may have pain because of venous insufficiency, varicose vein, we can treat the same one. If it's from PAD, peripheral arterial disease, guess what? We can treat that as well. So send all your knee pains to us, we tell the referring physicians, and we'll do a extensive evaluation and see what's their underlying cause. We can treat many of them ourselves, and if needs be, we'll refer them to a proper specialist.
I think that's why it's so important, even from a business and marketing standpoint, to do the education that you and your team do, because you being able to know these procedures and these disease states has allowed your business to grow, because that patient goes so many more directions now.
That's true. That's true.
So let's get a little nerdy, because we're here at OES. We're in the with all the equipment. What kind of new technology did you get this year? Because I heard you guys got some new toys.
We have a new toys. One that is actually making a huge difference for us is this angio unit, in which we use vessel mapping. So we do a spin CT, we map out the vessels, we project them on the patients, and it's locked to the patient. So if we move the table, we move the gantry, we change orientation of the camera, we elevate or decrease the height of the bed, that 3D model is locked to the patient, is still very active and effective. We also do Embo Assist, that's a product from GE that helps us a lot. And we have experimented with some other ideas that are still in their infancy. For example, we tried out this AR, augmented reality goggles, in which we have these goggles on our head. You can see the fluoro live. You can actually do fusion with prior CT or ultrasound. And when I move throughout the room, that the screen is moving with me, so nobody needs to adjust the big angio unit screen.
Now, I'm just curious, because that sounds cool, but I feel like that'd be kind of disorienting at first. Was that fun, or was it weird?
It was very fun. It wasn't disorienting, but it has so many features that we can use, and it takes time to learn every single feature to optimize it. But even if you don't optimize it, it's very effective and useful too.
Well, I will say you guys are always on the front end of everything, and just on research, on technology, on marketing. I love watching you guys practice grow. Thank you for being on. I really appreciate it, Dr. Astani.
Thank you, Justin.